welcome to today's acid-base session. We're going to continue with the theme of how well you know the 6 clinical acid-base rules so that you can apply them to the diagnosis of patients. So I'm going to start off with these numbers, and the question is, what is the delta bicarbonate to delta PCO2? So why don't you all write that down? So the question is from the original normal bicarbonate and PCO2. This is a male, by the way. The bicarbonate's 25 and the PCO2 is 40. These are the abnormal numbers. What is the change in bicarbonate to change in PCO2, or same thing, the delta bicarbonate to delta PCO2? So you first have to do that in order to come up with the acid-base diagnosis. So it's pretty trivial. The answer is a change of 10 for the bicarbonate to a change of 20 for the PCO2. And the way the rule is typically written, and it's more historic, is that for every 5 change in the bicarbonate, the PCO2 changes by 10. Or you can say the opposite: for every 10 change in the PCO2, the bicarbonate changes 5. You would do that because the chicken here is the PCO2. Once you know what acid-base disorder this applies to, you could actually divide by 5, further divide by 5, and say that for every 2 change in the PCO2, the bicarbonate changes by 1. But historically, and just what's been accepted over the years, it's typically written this way: for every 10 change in the PCO2, the bicarbonate changes by 5. So everything above that, like this patient where the change was 20 to 10, you would simplify it to this expression. Okay, so then the question becomes, what acid-base disorder has this rule? And I would like you, we're going to have you enter that in the poll, and then we'll look and see what the results are. So which of the 6 acid-base disorders do these changes apply to? Okay, has everybody entered their results? Okay, I assume everybody's entered. So the correct answer is chronic respiratory alkalosis. In chronic respiratory alkalosis, which would be a woman who's pregnant, patient with emphysema, someone who lives at high altitude, or a patient with chronic liver disease, they hyperventilate and they do it chronically. And when you look at their numbers, for every 10 decrease in the PCO2, the bicarbonate is changed by half. So the answer here is chronic respiratory alkalosis. Okay, here's another patient. These are the normal numbers. The PCO2 is 38. The bicarb is 23. If I've told you those numbers are normal, you know it must be a female. Remember, females have a slightly lower PCO2 normally and a slightly lower bicarbonate. You just don't see these in males. Okay, so she started off with a PCO2 of 38, and now it's 28. And the bicarb was 23, and now it's 15. So the question again is, what is the change in PCO2 to change in bicarbonate? And once we know that, we'll figure out what the acid-base diagnosis is. And again, as I always say, I'm leaving out the pH because you do not need the pH at all to diagnose clinical acid-base disorders during your fellowship, when you finish, or on an exam. These are the only two numbers you need. So what is the change in the PCO2 to change in bicarbonate? Again, you just subtract from what the original numbers were. And in this particular patient, the bicarbonate changed by 8 and the PCO2 changed by 10. And we simplify that to a change of 1 to 1.2. So the PCO2 changed a little bit more than the bicarbonate changed. Essentially 1 to 1, but if you want to be exact, there's a slightly greater change in the PCO2 than the bicarbonate. So the question is then, which of the 6 acid-base disorders has these 2 changes from normality? And if you could enter your answers on the poll. Okay, I think there's 2 people left, so the answer is correct. It's metabolic acidosis compensated. Remember that the only simple acid-base disorder, if it's metabolic acidosis or alkalosis, it must be compensated. Because if it's not compensated, then you have not only metabolic acidosis or alkalosis, you have a respiratory acid-base disorder in addition. So if you have these changes, not only must you say it's metabolic acidosis, but you have to say it's compensated, because that's the full definition of the simple acid-base disorder, metabolic acidosis or alkalosis. So I hope that's clear. So that's correct. This is a compensated metabolic acidosis. Okay, here's another patient, 40 and 25, likely a male. And now the abnormal numbers are the PCO2 is 70 and the bicarbonate's 35.5. So again, calculate the change from normality for each of these, and then we'll figure out what the acid-base diagnosis must be. So has everybody got those changes? Okay, so the bicarb increased by 10.5, the PCO2 increased by 30. Again, when we have something like this, we tend to go to 10. Obviously, we could divide this further. We could divide the 3.5 into 10 and get 2.7 something, but it's usually written like this, that for every 10 change in the PCO2, the bicarb changed 3.5. And obviously, if the PCO2 had changed by 20, the bicarb would have changed by 7. So it's linear in that sense, but we simplify it down to the PCO2 changing by 10. So then the question becomes, what acid-base disorder has this ratio? So again, if you could enter your answers in the poll. Okay, do we have everybody? I think we have 2 people. Okay, I'm not sure we have everybody, but yes, the correct answer is chronic respiratory acidosis. In someone who hypoventilates chronically, either someone on a ventilator or typically a patient with COPD who's a chronic bronchitic. Remember, the chronic bronchitic has chronic respiratory acidosis, the so-called blue bloater from medical school, as opposed to the emphysematous patient who is the pink puffer. They hyperventilate. They're ventilating better than all of us. They have a low PCO2, and they have chronic respiratory alkalosis, like the liver patient or someone who's pregnant. So yes, these numbers are, you would only see these numbers in chronic respiratory acidosis. Very good. Okay, here's another patient, likely a female, PCO2 is 39, PCO2 is normally 24. And now we have these new numbers. So first calculate your deltas. So again, we typically simplify down to 10 in these kind of patients. And so the PCO2 changed by 10 and the bicarb changed by 2. So again, what acid-base disorder do we typically see this in? Again, you could simplify it down to 1 to 5 if you wanted to. You just don't see that in the textbooks. Okay, well, the correct answer, when we have a change of 10 in the PCO2 for 2 of bicarbonate, that's what you see in acute respiratory acidosis. So someone who suddenly hypoventilated, let's say you had a patient who was normal and the vent setting was too low. You would see these kind of changes. If the PCO2, let's say, went to 50, the bicarb would increase by 1. If PCO2 went to 60, the bicarb would increase if the PCO2 went to 50, the bicarb would go up by 2. If the PCO2 went to 60, the bicarb would go up by 4, that sort of thing. So this is what you see with acute hypoventilation. If you kept this going chronically, the bicarb would go up another 1.5. That's where we get the 3.5 from. But 2 out of the 3.5 comes just from the acute phenomena, which again is something that doesn't require kidneys or any organs. It's a titration of all our non-bicarbonate buffers in the body when you raise the PCO2. The same thing occurs if you have a bottle of soda and other buffers in there and you start bubbling it with carbon dioxide, you would see the bicarbonate start increasing. Okay, here's another patient. Again, likely a female. The PCO2 is 38. The bicarb starts at 23. And again, it's important to realize that when you see this, don't start thinking there's abnormality. And if this was a male, these would be abnormal. So you really have to know what kind of patient you got the results from. But in a female, this would be perfectly normal, and that's your new norm that you calculate your deltas from. Or not the new norm, it's the norm that you calculate the deltas from. So here, the PCO2 started at 38 and it's now 45. The bicarb's 23 and went up to 33. So the question is, what acid-base disorder? Well, first of all, what are the deltas? So these are our deltas. Our bicarb went up by 10 and the PCO2 went up by 7. So the question is, with this particular proportionality, what acid-base disorder do we get this in? So let's go to the next poll. Anybody else want to enter the poll? Okay, so you only see this in metabolic alkalosis compensated. For every 10 increase in the bicarbonate, the PCO2 goes up by 7. If the bicarb went up by 20, the PCO2 will go up by 14. And again, it has to be compensated for it to be a simple acid-base disorder. Because if the PCO2 didn't change by what you predict, then by definition, you have a respiratory acid-base disorder. If it's above what you predicted, it's respiratory acidosis, in addition to the metabolic alkalosis, which is not a simple acid-base disorder, which is all we're showing today. And if it's below what you predict, so in other words, in this particular patient, if the PCO2 was predicted to go up by 7 because the bicarb went up by 10, if the PCO2 went up by 3, that's not enough compensation, and you by definition, don't have a simple acid-base disorder. You have a respiratory alkalosis in addition. Even though the PCO2 was up by 3, it's still above normal, but it's a respiratory alkalosis because it should have gone up by 7. So these numbers are compatible only with a compensated metabolic alkalosis. Okay, here's another patient. The PCO2 went up by a certain amount and the bicarb went up by a certain amount. And when we do the math, the PCO2 went up by 20, the bicarb went up by 2. And again, we tend to, in the literature, simplify this to a 10 change in the PCO2. So the PCO2 went up by 10 for every 1 increase in the bicarb. So which acid-base disorder, if you could open the poll, is this compatible with? Okay, so this is what we see in acute respiratory acidosis. Very good. So for every 10 increase in the PCO2, the bicarbonate goes up by 1. In acute respiratory alkalosis, you get that 10 to 2 change. Is a little bit more of a fall. I think let me just go back to this other case because I might have misspoken. I want to make sure I didn't. Yeah, this is acute respiratory alkalosis. If I said acidosis, that was a mistake. So the answer here is E. For every 10 change in the PCO2, the bicarbonate changes by 2 in the down direction. So chronic respiratory alkalosis is a further fall of 3. Okay, so the total 5 is composed of 2 from the acute fall and then a further 3 from the kidney changing its net acid excretion rate, and you get a further fall of 3, so the total would be 5. But acutely, with acute respiratory alkalosis, it's 2. But in the in the acute respiratory acidosis, when you raise the PCO2, the bicarb does not go up by 2, it goes up by about 1. And then if you keep that going, there's a further 2.5 increase, which makes the total 3.5 for every 10 chronically. Okay. So now I'd like you to choose which of these. We're talking now about the time it takes to reach a steady state. So which of the acid-base disorders takes 2 to 3 days to reach a new steady state? If you could take a stab at that. And again, don't be afraid to just put something. It's better to put something than not enter anything. Okay, again, it's important to memorize these times because if you don't know that, you're never going to know whether you're in between the creation of something and its final steady state and you have a simple acid-base disorder, you didn't wait long enough, or you have a mixed disorder. So you must know, if possible, how long the clinical entity has been going on. Now, oftentimes we don't, but if you do know, you'll be able to make that distinction. Otherwise, you're just going to make a mistake when you try to make an acid-base diagnosis. So the acid-base disorder that takes 2 to 3 days is chronic respiratory acidosis. None of the acid-base disorders take this duration of time. Some take longer, some take less, but none of them take that sort of duration. Okay, what acid-base disorders take? What acid-base disorder takes a day to a day and a half till the numbers finally stop changing? Okay, again, there's no rhyme or reason for this. It's just something you have to memorize. This is how long it takes in metabolic alkalosis for the PCO2 to stop increasing. So again, if you're vomiting or you're on Lasix or you have some new event initiating a metabolic, we're not talking about Barter's or Gittleman syndrome. They've had it from birth. It's obvious that the day and a half have gone by. That occurred, when they were just newborns. But as far as something where it was created by a pill or the patient itself, it takes a day or a day and a half for that PCO2 to stop increasing. If you come in too early, you're going to think that there's a respiratory acid-base disorder going on. You can come in too late, that's fine. You can wait 2, 3, 4, 5 days because nothing will happen after the first day and a half. So as long as you wait long enough, you're fine, but you can't be too early or you're going to make a mistake. So again, a day to a day and a half is the time it takes for the compensation and metabolic alkalosis to occur. In other words, when you raise the bicarbonate, let's say in that patient I just showed by 10, it'll take about a day or a day and a half for the PCO2 to hit 47. If you come in half a day after the vomiting started, it may only be 43 or 44. If you come in 3, 4 days later, it'll still be 47. You're fine, but you have to give it enough time. Okay, what about half a day to a day? Yeah, so the one that's the shortest time is the compensation for metabolic acidosis, or what some people like to remember from medical school and residency, the Winter's formula. Winter's formula doesn't tell you how long it took to achieve it. This is a separate concept. How long does it take the PCO2 to stop falling? So if you get ketoacidosis or you get a lactic acidosis, whatever the reason for the new onset metabolic acidosis, your medulla senses that and you start increasing your ventilation, but the PCO2 doesn't start flattening out and reaching a new steady state until about half a day to a day. If you come in too early, again, you're going to think there's a mixed acid-base disorder present. If you come in after a day, you're fine, but you have to give it at least half a day to a day to achieve that 1 to 1.2 expected proportionality. Okay, which acid-base disorder takes 3 to 5 days till a steady state is achieved? Okay, this is what you see in chronic respiratory alkalosis. So if someone just was hyperventilating and you're following the bicarbonates over time, it's going to take 3 to 5 days for that bicarbonate to stop falling and reach its expected level of half of whatever the PCO2 fell. So for every 10 fall in the PCO2, the bicarb falls by 5, but initially you get the acute response. So it'll fall acutely by 2, as we said before, but then you have to wait another 3 to 5 days for it to stop falling. And there'll be an additional fall of 3 for every 10 fall on the PCO2 that takes about 3 to 5 days till you get the total of 5. Now, typically we don't see the initiation because we're dealing with someone who's a chronic liver disease patient, or you see a woman who's in the 2nd or 3rd trimester of pregnancy. You never really saw the onset, so you're always seeing it after 5 days. But if it just suddenly occurred, typically in someone who was hyperventilated, or you had a patient with anxiety who continued to hyperventilate over the week, it takes about 3 to 5 days for that bicarbonate to stop falling. And again, you distinguish this from metabolic acidosis, where you can have a significant fall in the PCO2 and bicarbonate, because in chronic respiratory alkalosis, it's 2 to 1. For every fall in the PCO2, the bicarb fell half of that. So for every 10 fall in the PCO2, the bicarb fell 5. In metabolic acidosis that's compensated, the changes are about equal, 1.2 to 1 or 12 to 10, however you want to memorize it. But they're rough. The concept is the changes in compensated metabolic acidosis are about equal. Whereas in chronic respiratory alkalosis, where you also have a fall in both that can be significant, the PCO2 has fallen double what the bicarbonate falls. So you can just eyeball it immediately and distinguish those two. And the acute respiratory acidosis and alkalosis are both minutes. And I don't know of exact studies in large populations showing how many minutes, but the idea is it occurs very quickly. You don't have to wait half a day or a day for it to occur. So as soon as you, let's say, hyperventilate acutely because you're very anxious, the bicarbonate will fall 2 for every 10 fall in the PCO2, and that fall of 2 will occur over minutes. It won't take longer than that. But remember, if you keep the PCO2 decreased over the next day, day and a half, etc., the bicarb keeps falling, not because of the acute issue, but because now the kidney starts kicking in and changes its net acid excretion, and your bicarbonate keeps falling and falling until 3 to 5 days later where it stops falling. Okay, so just a couple of patients to recap what we talked about before. It's a 58-year-old male who's vomiting. And again, you can look at the total CO2 from the chem panel if you want. It's roughly equal to the bicarbonate. Remember, it's only different by 0.03 times your PCO2. So here we have a bicarb of 35 and a PCO2 of 47. Again, I'm leaving out the pH because we don't need it. You calculate the change in the bicarbonate from change in PCO2, except here we don't know the normal numbers. So we have to assume population normal of 25 for the bicarb because it's a male and 40 for the PCO2. So the PCO2 has changed by 7 and the bicarb's changed by 10. What acid-base disorder is compatible with that? And the answer is metabolic alkalosis that's compensated. It's the only acid-base disorder where you get this proportionality. Okay, here's a 27-year-old male, and the PCO2 is 27, the bicarb 14. Again, the total CO2 is slightly above the bicarbonate because it's 0.03 times the PCO2 plus the bicarbonate. Remember not to call this number bicarbonate, it's the total CO2. Okay, so again, what are the proportionalities? Again, we don't have the original numbers, which would be typical of patients clinically. The bicarb changed by about 11. We'll have to assume it's normally 25. The PCO2 we'll have to assume started at 40. So it changed by 13. So again, we have this proportionality of 1.2 to 1. And again, there's only one acid-base disorder where you would see this, and that's a compensated metabolic acidosis. Okay, again, the changes are roughly equal. If these numbers were chronic respiratory alkalosis, the bicarb would have had to have fallen half of what the PCO2 fell, not roughly the same changes. You would see if this PCO2 fell because of chronic hyperventilation of 13, then the bicarb would have fallen by 6.5, not by 11. Okay, here's an 18-year-old male with anxiety, and you see the PCO2 and bicarbonate here. Again, we don't have original numbers from the patient, so we have to assume population norms. We calculate the changes, and we get these kind of changes, and this is what we see in acute respiratory alkalosis. Remember, this occurs over minutes. If it was acute respiratory acidosis, it would be 10 to 1 acutely. So the bicarb falls slightly more when it's alkalosis, both acutely and chronically. It's an easy way to remember. So with chronic respiratory alkalosis, this is 10 to 5. But if it's chronic respiratory acidosis, it's 10 to 3.5. So the change of these numbers here is always less acute and chronically in respiratory acidosis, whether it's acute or chronic. And you can also remember that it takes less days in the acidosis direction to reach the steady state. So in chronic respiratory acidosis, it takes 2 to 3 days to achieve the chronic numbers, whereas in respiratory alkalosis, chronic respiratory alkalosis takes 3 to 5 days. So both the magnitude of the change is greater in respiratory alkalosis, whether it's acute or chronic, and it takes longer to achieve the new steady state. So it's an easy way to remember those things. All the numbers are bigger. Okay, here's a 60-year-old male with these numbers, the PCO2 70, bicarb 36, and we'll calculate the changes from normality, and it's roughly 30 to 11, or this kind of ratioing. And then again, we see this only in one acid-base disorder, chronic respiratory acidosis. And the most common reason would be probably chronic bronchitic. Okay, I think we'll stop there today. So again, please memorize the acid-base rules. If you do that, this will be a piece of cake. If you don't do that, you're always going to be thinking of what it could be. That's sort of the bedrock. You have to memorize what they are, and then you just apply them. You ask the question. Once you know the rules, you ask the question, what does my patient have? And if it's not one of the 6 rules, then you get into more complexity. You have a mixed acid-base disorder. Either you have a mixed acid-base disorder, or you came in too early before the rule steady stated out. And so that's why it's important to know how long it takes for each of these things also to achieve a steady state, so that you don't get fooled into thinking there's more than one acid-base disorder. You would tell the house staff, for instance, let's say the patient developed lactic acidosis, and they're getting the numbers and it looks like it's not compensated yet fully. Well, it could be that you have a respiratory acid-base disorder and it'll always look like that. Or you should be telling the house staff, let's just wait a day, we'll repeat the numbers, and then we'll see whether it's a simple acid-base disorder, compensated metabolic acidosis or not. But you have to know what to tell the house staff, either to wait or the numbers are fine and we have a mixed disorder. Okay, everybody, I think I'll stop there. Does anyone have any questions about that? So please go out and memorize those rules so that they become second nature. Once you've learned them, it becomes very easy. Okay, well, I think I'll stop there, and have a great day, everybody.